Well, good afternoon, everyone, or morning, depending on where you're at in the U.S., and welcome to this webinar. This is Steve Modronock, and I'm Executive Director with the Association of Food and Drug Officials, and we're pleased to bring today this webinar forward. This webinar is going to be presented by Dr. Leanne Jacobs, who is the William Neal Reynolds Professor in the Department of Food, Bioprocessing, and Nutrition Sciences at North Carolina State University. Her formal training is in food safety, food microbiology from Purdue, food safety and food microbiology from Purdue University, and environmental sciences and public health from the University of North Carolina at Chapel Hill. Dr. Jacobs is probably best known for her efforts in food virology, having served as the director of the USDA NIFA Food Virology Collaborative, or NORCOR project, for over 7 years. She has 30 years of experience training undergraduate and graduate students in food microbiology, leading food safety research projects, and working with external stakeholders in the food and beverage industry, sanitation and hygiene sector, and with cruise lines. Her professional activities have included membership on the National Advisory Committee on Microbiology Criteria for Foods, participation in several national academies, consensus studies, and as a member of the Food and Nutrition Board, and as a member of the Executive Board of the International Association of Food Protection, or IAFP, for which she served as president in 2010 through 2011. We are very pleased to have Dr. Jacobs with us today to present, and as you all know, there's probably no one that knows virology better in the food world than Dr. Jacobs. We're excited to welcome her, and let's go ahead and get started. We will take questions at the end, largely through the chat screen. So if you have a question, go ahead and put it in the chat window, and we'll work our way through those questions at the end.
Okay, well, good morning or good afternoon to everyone who was kind enough to join this presentation today. This is a new beast for me. I'm a food virologist, but I don't work with these kinds of viruses, so I had to quickly educate myself. And what I hope to provide for you today is a very comprehensive background. Let me see. I'm having trouble getting the screen to move forward, you guys who are controlling things. So it's not allowing me to change slides.
Let's see.
Yeah, I got it now. Perfect. Okay. There must have been a switch to flick. So by way of outline, this is pretty up to date. I went in and added a few things this morning. I'm going to provide you an introduction, a little bit on the epi and transmission of this virus, what we know about environmental persistence, inactivation, and disinfection, and then I'm going to finish up with some discussion of control and conclusions. So what we call the coronavirus, human coronavirus 2, which causes the COVID disease, is a very different beast from foodborne viruses, and I would actually not even call it a foodborne virus, and I think you'll understand that by the end of the presentation. In point of fact, coronaviruses have been around forever, and we've known a lot about them well, certainly some of the less invasive or those causing a little bit less severe disease. And usually those cause either a mild respiratory disease like the common cold or a gastrointestinal disease. They kind of came into vogue or came into sort of more noticeable attention with the SARS coronavirus that occurred in 2003, and then that was rapidly followed by MERS, well, about a decade later, which was causing disease between 2012 and about 2018, and then this new one here. Just a little bit about SARS and MERS. SARS has caused about 8,000 cases, mostly in China, and about 800 deaths, but it was pretty quickly contained. MERS, which is the Middle East respiratory syndrome caused about, over a period of maybe 6 years, about 2,300 cases and about 800 deaths. So pretty pathogenic, mostly in Saudi Arabia, but there was a sizable outbreak that occurred in Korea. Interestingly, with MERS, there was no substantial community transmission. It was largely a nosocomial infection. So SARS coronavirus 2, which is the cause of this COVID-19 illness that we're dealing with right now, has some features, some kind of structural features that make it very different from noro and Hep A, which are the things that we usually worry about in the food industry. If you look over on actually, I think I'm going to go back to the previous slide. If you look at the left-hand structure of the virus, it's a pretty simple structure. It has a two-layer lipid envelope. Lipid, again, fat, which kind of surrounds the virus. And then sticking out of the envelope are these protein spikes, which are the purple images. And those actually are hold the receptors that the virus binds to the host cell. They're generally glycoprotein in nature. And then within the virus itself is a piece of genetic material, and that piece of genetic material is actually a single strand of ribosomal nucleic acid, or RNA. So as an enveloped virus, in other words, having this lipid coat rather than a protein coat, which noro and Hep A have, they're generally considered to be pretty fragile, pretty environmentally unstable. But this guy is a little different because it is much more environmentally stable. Now, we do have some animal surrogates, and we fortunately have been able to cultivate some of the human coronaviruses, including SARS and MERS, as well as COVID-19. It's not easy. You have to use BSL-3 facilities. It's difficult to get the virus, but we actually can cultivate them in African green monkey kidney cells. But a lot of the data I'll show you, because this virus is so new, a lot of the data I'm going to show you is actually done with SARS or MERS or some of these less pathogenic coronaviruses. So I'm going to launch into a little bit of discussion about the epidemiology, talk some about the origin of this particular virus, symptoms and outcomes, incubation period, reproduction number, and a little bit on the current disease trajectory. So the origin is really fascinating. Actually, for SARS, MERS, and SARS-2, the origin appears to be bats. And that's pretty well vetted now in the scientific literature, that bats are the original source of the virus. Now, the viruses are very species specific. They don't jump species very easily. So they have to go through some sort of a mutation or genetic change in order to be able to jump species. And what these viruses seem to have done is they've chosen a secondary host. So they jump from bats to another host, and then from that host to humans. And in the case of SARS, that secondary host was a small animal called a civet. In the case of MERS, that secondary host was actually the dromedary. For SARS-2, we don't know what that secondary host is. There's some hypotheses out there, but that is exactly how this happened. The virus from bats went to a secondary host and then ended up in humans. So this is a slide that gives kind of the trajectory of illness. In other words, from mild to severe to death, and the symptoms that are associated with that illness. I don't want to go into a lot of detail. The slides will be made available so you can look at them at some point. I think the whole presentation is going to be made available. But by and large, most people have mild illness. But the severity of illness is kind of this trajectory from, just needing to kind of watch somebody to all the way to having to be on respiratory support. One of the things that's important to realize is that there are significant comorbidities associated with the very severe outcomes. And actually, I didn't put age here as a comorbidity because it's kind of, I think, pretty widely understood that with advanced age, you have a much worse prognosis with this illness. But from a disease standpoint, the significant comorbidity overwhelmingly is cardiovascular disease and hypertension. And from some of the literature coming out of China shows that up to 30 to 50% of the people who were killed from this virus actually did have cardiovascular disease and hypertension. The second to that is diabetes. And then other things like malignancies, immunocompromised status, kidney disease also fall as comorbidities, but they're less prevalent than the cardiovascular disease and diabetes. And there is some discussion. It hasn't really been proven, I think, clinically, that in some cases there is some permanent pulmonary damage for those people who have experienced severe disease. So this table I pulled out of a CDC report on hospitalization, ICU, and case fatality rates for this period of time in the United States. I do bring up the fact that these certainly all of these different rates can change very dramatically depending upon access to health care, the country, et cetera, and so on. But what I want to kind of point out is you can see the hospitalization rates we're seeing, at least in the United States, hospitalizations occurring in pretty much every age group except the youngest age group. And they do increase a little bit with age, but certainly ICU admissions and case fatality rates increase significantly with age. But also keep in mind that this table could look very different if it came from another country or even if it came from an individual state, because individual states are responding in different ways. I wanted to talk a little bit about where that 14-day incubation period came from. So it looks like the median incubation period for SARS-2 is about 5 days. And if you look at that with a 95% confidence interval, that's about 4.5 to almost 6 days. What we do is if we want to spread that confidence interval out and give us more assurance as to make sure that we're covering the breadth of that incubation period, then we can expand it out into the 99th percentile. And if you expand it out into the 99th percentile, the incubation period would be up to 14 days. And that's, I think, where that 14-day recommendation is, that people say, well, if you've been exposed or you think you've been exposed, then you need to be in isolation or social distancing, et cetera, and so on for 14 days. These are two epi curves. I did not update these, so these are from last week. They certainly would be slightly different. You can see on the left. Let's look at the right-hand curve. Shows the disease incidence rates over time for various countries, and the trajectories for the countries in part depend upon their controls. But they almost all are seeing some, pretty dramatic increases in cases in that period, sort of right before they instituted, or excuse me, right after they instituted isolation and social distancing rules. And the left hand is just an example of why we call this a pandemic. So you can see the yellow colored bars are cases that occurred in China, and all the other colors are in different countries or on different continents. And you can see that the disease clearly has spread to pretty much every continent at this point. And if any of you follow the Johns Hopkins site, which is a great site, you can see how it has systematically spread over time. So how is it transmitted? And I think the big question here is what bodily fluids is the virus shed in or can be found in, and then based on that, how is it being transmitted from one person to another? Now we use this term person-to-person transmission. I've always had a lot of trouble with what the heck is person-to-person transmission, and even some of the infectious disease docs I've talked to asked for more clarification. I've never really gotten that. So I think person-to-person is a bit of a black box, but that is how this virus is spread, certainly by aerosols from coughing and sneezing. Environmental surfaces are of concern. And there may be other mechanisms that we have yet to characterize. I would like to point out, and this is increasingly being recognized, that the virus is transmitted during the incubation period by seemingly uninfected individuals, perhaps children, because kids don't seem to show very severe symptoms. And actually, a lot of the transmission is occurring during this incubation period, which makes it, of course, very hard to control. So let's talk a little bit about the bodily materials that have been associated with or for which we found the presence of or evidence of this virus. And both of these are studies out of China. In both cases, they looked for virus in stool, certainly oropharyngeal swabs. In the study, the table of which was taken from on the right-hand side, they also looked at some other body fluids. The bottom line is that you can pretty consistently detect evidence of virus in human feces and in sputum or oropharyngeal swabs, and not in other bodily materials, bodily excrements. It's really important to keep in mind that the early studies used PCR-based molecular methods to detect evidence of viral RNA in these bodily materials. And that's not telling you whether the virus is infectious. It's only telling you that you have presence of viral RNA. Very recently, in the last in the last week, a couple of studies have come up that have shown that they are able to cultivate virus from the feces of infected individuals. How often infected individuals shed virus in their feces is unknown. I'm hearing a number of about 50%, but I think it certainly depends on when in the infection cycle a fecal sample would be drawn. And there does appear to be evidence that there is long-term shedding over time. And when I say long-term, I mean weeks after people have recovered. So that leads me into a little bit of a discussion about personal protective equipment. I traveled probably 3 weeks before, this kind of really hit, and saw several people wearing surgical masks in the airport. I there certainly has been discussion about the food industry using surgical masks. And the bottom line is the scientific consensus seems to be that surgical masks are great. Well, maybe not great, but they're certainly helpful in preventing aerosols from an infected person from being released into the environment. So they can protect people around an infected individual from getting infected themselves. So they limit spread through aerosols, but only if you're an individual who's showing those symptoms. They're not protective of uninfected individuals. In other words, they're not going to protect you from getting the infection if you're surrounded by individuals who are sick. And one of the problems is that they may actually be a reservoir for contamination, because virus particles could sort of get trapped on the outside of them, and then you use your hands to take the mask off and you have virus on your hands. There was a lot of talk about N95 respirators. This is a bit less relevant now, because only N95 respirators are only going to healthcare. Bottom line is that they're tight fitting. You need to have special training. They're not intended for the general population. They are protective of individuals of individuals who could potentially be exposed, but they are not something that would be or could be used at this point in by the food industry. And the next slide is just a sort of a fact sheet that I pulled off of the CDC website that explains the difference between these two types of face masks, if you'd like to look at those in further detail at another time. So another question is, how often or frequently and certainly how long after exposure to droplets or some sort of surface contamination does the virus seem to exist on surfaces or fomites? And these are a couple, the next two slides are a couple of examples I pulled from one from MERS and one more recently, in which people went in and looked for evidence of viral contamination on a variety of different surfaces, mostly in healthcare. And the bottom line is that you can find evidence of viral contamination by PCR on many, many different surface types, including restrooms in hospitals that have been caring for ill individuals. This second slide here that I'm showing you is again more recent. It's for COVID too, but you can see the sample size is really low. There's only a few, really only one or two representative surfaces of each type. I do want to point out in this particular slide that the CT values, those of you who are laboratorians, the CT values are pretty high. So that's suggesting that there's not much viral RNA on those surfaces. This is an area that we need to know a lot more about. I will also point out, I don't have a slide for it, but there was some evidence from one of the cruise lines that they were able to find evidence of viral RNA in cabins of people who were sick, who had vacated them 17 days prior to when they took the environmental samples. So there is concern that this virus is sticking around on surfaces for an extended period of time. I'll show you a little bit of science about that in a few minutes. I do want to caution that the environmental surveys, the natural environmental surveys, are done using PCR, so we don't know whether what you find on those surfaces is infectious. So this is, I was really fortunate to have found this review paper on environmental persistence and resistance of coronaviruses that was published really, really recently. And I'm using this as I'm going to show you a lot of data from this because they did a great job of putting all of the relevant papers together. So the bottom line is, and I underlined in their summary, relative to environmental persistence, that these viruses can persist on inanimate surfaces like metal, glass, and plastic for up to 9 days. And keep in mind that the studies you're going to see in the tables are actually quite diverse in which viruses they tested. And really, the MERS virus and the first SARS virus are the most relevant from a data perspective for the virus we're currently dealing with. So this is the table on persistence of coronaviruses on various types of inanimate surfaces, and you can see where they go from steel, plastic, PVC, ceramic, et cetera, and so on. I have actually boxed the data that is relevant relative to SARS coronavirus or MERS. And you can see if you just kind of look in the next to the last column, persistence varies from about a low of approximately 2 days to a high of approximately 9 days. Almost all of these studies were done at room temperature. The virus appears to persist longer at refrigeration temperature, and I think you could make the argument that it's more or less preserved by freezing. So freezing is not going to kill it, and it's not going to inactivate it really at all. The other thing I did want to point out is that there is some difference by surface type, but actually if you look at the data for Hep A and Noro, which are also highly surface persistent viruses, surface type tends to not make that big a difference. Certainly relative humidity can make a big difference, can make a difference, not necessarily a big difference. But I think the best studies are simply the ones that are done sort of at room temperature, because those are the circumstances under which and ambient conditions. Those are the circumstances under which we're exposed. So this particular study also looked at persistence, but in this case, this was done with the SARS-2 virus. So this is a very, very recent study, and these investigators looked at a bunch of different surface types, including copper. Copper's generally pretty antimicrobial, and they also looked at aerosol persistence. And I want to show you a little bit of their data. They estimated things a tad bit differently than we might necessarily do in food microbiology. They looked at what they called the half-life of virus persistence, so when you lost 50% of the titer of the virus. So the best way to look at these graphs, I think, is if you look at B, the horizontal graphs on B, these are the half-lives of coronavirus 19 and SARS coronavirus 1, which was the very first SARS virus. And you can see here in aerosols, the half-life is somewhere around 3 hours. If you look above that, it'll give you sort of a feel for the confidence intervals, but also approximately how long it takes for the virus to reach a non-detectable state. And this was done in cell culture, so they were actually looking at infectious virus. And you can see here for aerosols, for example, for coronavirus, I can use my pointer. For coronavirus 19, you're seeing reaching kind of non-detectable levels at about 30 hours. And then it differs depending upon surface. It's not terribly persistent on copper, which isn't a surprise because copper is pretty antiviral. If you look at something like stainless steel, you're seeing persistence to non-detectability at somewhere around 60-ish hours, something like that. I do want to say something about the aerosols because I've gotten a lot of questions about this. This was a very controlled study. They actually used an aerosolization drum and they used a nebulizer. And so these are aerosols that they were able to keep in the air for long periods of time. The reality is that when people cough or people sneeze, they're releasing droplets, and those droplets usually don't stay in the air very long, and will rapidly fall to surfaces because they're large and they're heavy. So from what I've read, there I think is one anecdotal instance where there was concern that actually aerosols got into ventilation systems and kind of went all around a physical location up through multiple floors and stuff. But there isn't a lot of evidence that that is actually happening in real life, at least not yet. Darnell and his colleagues did a lot of work on inactivation of coronavirus under conditions that might be relevant to food processing. What they found is that and this was with coronavirus, the first coronavirus. They found that the virus is pretty sensitive to UVC, but not so much to ultraviolet A rays. They also found, if you look to the right-hand side, they have a nice graph of pH. They found that the virus at sort of room temperature seems to it becomes sensitive to pH somewhere between 5 and 3. But if you put it under colder temperatures, it becomes less sensitive to pH. And then at high pHs, it also is, at very high pHs, it's also sensitive. But it actually has a pretty, for an envelope virus, it actually has a pretty wide range of pH stability. The thermal inactivation data, and these were, which is on the left-hand side, and these are pretty simple experiments. They basically put the virus suspension into, into like small Eppendorf tubes and heated for a certain amount of time. So it wasn't a sophisticated thermal inactivation study. And it was very interesting in reading this paper because if you look at the middle graph, which is the 65 degrees centigrade graph, they show that at about 4 to 5 minutes at 65 degrees, you're at your limit of detection of the cell culture assay. But it's pretty much the same thing at about 75 degrees centigrade. And I was a little confused about that when I looked at it. And what the author said is that there did seem to be a subpopulation of virus particles that were more resistant to temperature. And they stated that they thought that was probably a function of aggregation, and I think that makes a lot of sense. We've seen that with other viruses relative to thermal inactivation. I would caution that when we're dealing with foods, we may or may not have viral aggregation, but we certainly will have protective effects of the food matrix, and none of these studies have been done in foods. Now, with that, before anybody kind of wigs out or thinks, oh my God, standard methods don't work, a great paper came out. This is an opinion that was done by the French Agency on Food, Environmental, and Occupational Health and Safety. And I just got access to it a couple of days ago. But they went through the literature and they looked at thermal inactivation or thermal sensitivity of lots of different coronaviruses. And their conclusion was that if you cook for or heat process for 4 minutes at 63 degrees, you can consider that the virus has been inactivated. Certainly if you're using pasteurization types of conditions, you can consider that the virus is inactivated. What about disinfection? what I did here, again, is on the left-hand column, I circled some of the disinfectants that are most relevant to the food industry, and then the relevant data on the right-hand column. This is a very busy slide. There's a lot of data. I point out that these are suspension tests. So suspension tests are where you basically just add a virus suspension to the disinfectant solution. In almost all instances, viruses are more susceptible to a disinfectant when you use a suspension test than when you use a surface test. The key take-homes here are that ethanol at 60% or higher is effective. So is isopropanol. Unfortunately, we don't use those for disinfection in the food industry per se, although we do use them in hand sanitizers, and as components of hand sanitizers, they should be quite effective. Hydrogen peroxide at about 0.5% or above seems to be pretty effective. Sodium hypochlorite is effective at higher concentrations, but not at lower concentrations. And in doing the conversions from percent to parts per million, it looks like that about 1,000 parts per million is kind of your cutoff for efficacy. So 1,000 parts per million or higher is efficacious. Benzalkonium chloride is a big black box. In part because it hasn't been studied very much, and in part because when it has been studied, the results have not been, we haven't seen full inactivation of the virus. So this is also from the Kampf paper, but it's the surface tests, and if you can see, of course, there are a lot less surface tests than there are suspension tests. And again, ethanol works. Peroxide works, higher concentrations of sodium hypochlorite, but BACs are a bit of a black box. The conclusion that these investigators made was 62+% ethanol, 0.5% hydrogen peroxide, 0.1% hypochlorite, which is 1,000 parts per million for 1 minute, should be reliable for surface disinfection. And that the jury is really still out on BAC and a couple of the other disinfectants. I do point out that we have no data on peracetic acid. So unfortunately, I can't really comment on that from a data perspective, although I can give an opinion if somebody wants that during question and answers. I also point out that BAC products, formulation matters, and BAC products many times are formulated with a detergent. One would expect a detergent or a surfactant to inactivate or at least partially inactivate this virus. But again, we just don't have the data. So we just don't know how well BAC products are working. And this is just some discussion points from that paper that you might want to look at some point. I'm sure you guys are aware that we don't have a hand sanitizer. At least we're not able to get commercially available hand sanitizer because that's all being pretty much diverted to healthcare now, and that's appropriate. The WHO has guidelines for manufacturing your own hand sanitizer. Basically consists of ethanol, hydrogen peroxide, and a little bit of glycerol. Interestingly, those guidelines are provided in the case for use in the case when hand sanitizers are not available. And fairly recently, they were vetted in a scientific study, the results of which are on this slide. And that study did show that they do show efficacy against a variety of coronaviruses. So those formulations, I think, are reliable. And I do believe there are some, there now is kind of a federal mandate that's allowing distilleries and such to manufacture these products as long as they use the WHO guidelines. So this brings me to the EPA N list of products, which is how we're deciding, which is kind of how we're deciding what disinfectants to use. And in Peru, and this is a huge long list, has lots of different contact times, includes tons of different products that are some ready to use, some dilutable, some wipes, and a huge variety of active ingredients. Bottom line is if you look at the N list, the vast majority, probably 80% of the products on the N list are quats or quat formulations. Interestingly, this whole efficacy of any of these products has recently been brought up by the press. This is something that I pulled off of CNN, actually the end of February, where the statement was, do these products really work? And I will tell you that and I don't know, I can't give you the specific EPA guidelines, but I do know that many of the products that make coronavirus antiviral claims are doing it based on some of, not on MERS or not on coronavirus 1, but are doing it on some of the older surrogate viruses that are less pathogenic. So maybe the relevance of those surrogates to the current virus certainly is unknown, and maybe one reason why they show efficacy. Again, it's a bit of a black box. Okay, so let's talk about control. Well, we all know that the virus is here. We really don't know how prevalent it is in the United States. Testing would help that, but
doing a webinar. I'm walking at 3 with the dog.
But we are actually having trouble testing in many states.
Inhaler and antibiotic.
I think somebody is not muted. Sorry, I lost my train of thought. We don't necessarily know prevalence, and a lot of the states are actually having trouble getting reagents to do testing. I know we are in North Carolina, for example. So that's an issue in our country. I think you probably have all heard of this issue of what we're really trying to do is flatten the curve, and the mechanisms by which we do that are things like social distancing, travel restrictions, containment, sanitation, disinfection, and perhaps some others. So really, without belaboring this point, because I think we're all familiar with it, is flattening the curve is about not overloading the health system. In other words, there are maybe not proportionally a high number of severe illnesses, but there's enough severe illnesses, and they're of high enough severity that they require hospitalization, in many cases ICU stays, and also respirators. And we only have so much of those in our hospitals. So flattening the curve is not necessarily reducing the number of infections, out those numbers of infections so that they occur over a broader period of time so we don't overload our health system. Social distancing, out of close contact, 6 feet is the general rule of thumb. Avoiding any kind of mass gatherings. I mean, we've gone down from gatherings of 500 people to 100 to, now the recommendations, I think, in many states are, less than 5, maybe even less than that. Of course, we all know social distancing requires big changes in how we work, how we play, how we interact with people, and we've all been impacted by, in many ways, by social distancing. We also know it comes with economic cost, and so really, and I think we see this right now, there is this balance between the cost of social distancing and isolation and the public health benefit of that. And we're working by the seat of our pants at this point. So containment is actually making sure that all cases are identified, controlled, and isolated. Again, you quickly want to identify infected and ill individuals. This is really, and then isolate them, provide appropriate PPE for your healthcare workers. If you can, track contacts and quarantine. And this is all so impacted by availability of PPE, which is a problem. Certainly ability to test, which is a problem. I think it's highly dependent on the fact that we have a long incubation period in which people are not even showing symptoms and yet they're transmitting the illness. And what do you do about that? As well as, and this is an area we haven't even studied, how long the virus could be shed in bodily materials even after a person has recovered. This is just, you can have, when you have time, take a look at this slide. This is a very cool modeling experiment that was done in relationship to the epidemic in China. And basically it shows that only instituting one control, in this case a travel ban, really doesn't do a lot. You have to use a food microbiology term, you have to use a hurdle approach relative to containment of this virus to have a significant impact on public health. And I think that's what we're all experiencing right now. This is the update from the last webinar that the FDA did, kind of their stance on COVID in foods and what they will and will not be doing relative to the COVID epidemic. Part of this has to do with the food supply, and part of this has to do with protecting employees at manufacturing plants, as well as protecting FDA's own employees. But I think that in bold, I've put kind of the most significant conclusions from this webinar. One is that they will not recall food because of sick or ill employees due to COVID-19. At least that's as of March 18th, 2020. And also they will focus really only on mission critical activities, which means that they won't be doing routine inspection or surveillance programs, and they will not engage in unannounced inspections, but instead everything will be pre-announced. Again, that's in part to protect everybody, the people that are involved in these. So I want to talk just a tad bit about legal and ethical considerations, and I suspect there's going to be a bunch of questions about this, because what do you do in terms of managing your workers? And CDC and FDA have been pretty silent on this, and of course that's exacerbated by all the things we've already talked about. So certainly we need to protect the confidentiality of their medical information. Under OSHA guidelines, employers do have a responsibility to provide a safe workplace, and we've never had to deal with defining safety in the context of a disease like COVID. There are changes to Family Medical Leave Act that are, I think, being debated in Congress. May actually be passed now. I don't know because of the new bill that was just passed. But there are lots and lots and lots of different considerations, and I do think that it would be worthwhile to have some conversations about this. Things like the cost of keeping the workplace safe, the need to balance financial decisions with public health decisions, the need to be aware of your obligations as an employer, particularly when things are changing so rapidly. Certainly all of these types of actions are going to involve blending public health with employment law, HR law, and hopefully will be directed by the science rather than by kind of fear. So in conclusion, I'm going to basically say we certainly need to be cognizant. We really need to be thinking on a minute-by-minute basis of how we could potentially be exposed, and consequently, we need to be cautious. Working with a lot of undergrads, young people, I say over and over again, be collective. Think about how your actions are impacting other people that may be more susceptible to severe disease than you may be. Be careful, and I think people are starting to be really caring, finding ways to take care of each other, even in the midst of social isolation. And these are my acknowledgments, people who helped me with the slides, people who helped me with some of the legal implications. At this point, there should be other trade organizations included in these acknowledgments as well. And with that, I'll take questions.
Also, we have several questions already here, and I think the first one that I saw a lot of, Dr. Jacobs, was quat ammonia. Is that effective or is that not? And I think there's been some varying opinions on that. Any thoughts on that?
You know, the quats are I am not willing to put myself out there in one way or another because there is no data. There's no data aside from what I presented.
Okay. Very good.
And I believe really, I mean, there is, I think, a private testing lab that's gearing up to do some coronavirus testing, which could be disinfectants. And I suspect they'll be up and running within a week. And I think one of the first things that needs to be done is to start looking at some of the quats.
Great. The next question we had was the chlorine-based sanitizers, it looks like, aren't effective at 50 to 100 parts per million, but that is near the standard numbers used in the food industry. So is what we're normally doing working?
Well, I hate to use the word norovirus here because I never thought I would, but the CDC recommendations for noro are 1,000 to 5,000 parts per million chlorine, and at least the literature is indicating that you may have to go up to as high as 1,000 parts per million chlorine, and I don't think those studies have looked at soil load at all. So we all know that chlorine is pretty impacted by soil load. So yeah, I mean, the whole rules about what level of chlorine you can use on food contact surfaces is a problem. It's an issue.
Absolutely. The next question is, why are some viruses, non-envelope, for example, considered foodborne and coronavirus not?
Well, coronavirus is an enveloped virus. It's not a non-enveloped virus. All the viruses that I know of that are all the viruses that I know of that we classically consider foodborne are non-enveloped viruses, okay? What non-enveloped viruses is, they're very, very simple. They have a protein coat and then a nucleic acid core, okay? We've historically said enveloped viruses are wimpy in the environment largely because they don't have a protein coat, but they have more of this lipid envelope, and that's less stable in the environment. But this is an exception to that rule.
So we actually just got another series of questions related to quats, and as I think we all know, EPA has several of the quats that are listed as effective with coronaviruses. But I think in your presentation you talked a little bit about how perhaps there was more to that than meets the eye. Do you want to kind of hit on that one more time for everyone?
Yeah, so here's the deal. So if you look at the N list, there's about 80% of the N list is quats. And and some of them make coronavirus claims and some of them don't. But the way that they test in order to make the claims is what virus they use to test to make the claims can vary. So, if something's been tested against MERS or SARS coronavirus, that's going to be this new virus is probably going to behave pretty similarly in terms of inactivation. But if it was tested against one of the older respiratory strains, maybe not. And I stress the maybe because I'm not saying yes or I'm not saying no. I'm just saying we don't know. I do think that it's important, very important, to recognize that quats formulation, quats are formulations, okay? And detergents and surfactants historically work on envelope viruses. They basically melt the lipid envelope. But the problem is this is a new beast, so we don't know for sure that that's the case. And we don't have any significant efficacy data one way or the other. So does that explain that?
Yeah, great. It was very helpful to me, at least hearing that explanation. The next question I'm going to go to is actually a pretty specific question related to the materials and how long they're active potentially on different types of surfaces. This question is from one of our extension educators, I believe. Use of cardboard for reused egg cartons holding a dozen eggs. A farmer asked me how long the virus lived on cardboard egg cartons because he got these returned to him and reused them for his egg customers.
I love it. I'm going to go back to that slide that shows the data for cardboard. It's interesting. I've had a bunch of people actually email me about cardboard. So there must be some people must be really interested in cardboard. Okay. So this is the slide. This is with the current virus, okay? And if you look at the half-life, they're saying the half-life is about 8 hours. And they're saying on cardboard, I'm going to look at the max, up to 60 hours before the virus would then become detectable. That's when you start with 3 logs. So that would be about a 2.5 log inactivation, something like that, given the detection limit of the assay. So, 60 hours is how many days? 3 days ish.
Yep.
Something like
70.
that.
Yep. 72 would be 3. Yep. So.
Yeah.
Yep.
Now, but keep in mind, these are all studies that are done in a lab, and so you have to take that with a grain of salt. But that is what the science shows.
So one of our next questions is a little more theoretical in perspective here. And the question is, how would the virus go from a secondary host to humans? Any guesses on how that might happen?
Well, I did, when I first heard the bat thing, I thought that this is really fascinating, okay? So I did a little bit of reading, not so much for this virus, but just this sort of mechanism in general. And it turns out that, first of all, these are RNA viruses, and scientifically, the RNA genome is much more error prone, so it's easier for mutations to occur in RNA viruses than in DNA viruses, unless they're segmented like influenza. And so these mutations probably occur naturally, and they probably occur all the time. And bats have apparently a very, very wide flight range, and they are frequently dropping. This is kind of disgusting because this probably happens to all of us. They're frequently dropping urine, feces, and aerosol droplets around when they fly. And so if you look at where these viruses have sort of emerged, they're out of these wet markets and these very, very high density population areas of the world. And apparently bats really, really like wet markets. And so it's probably natural mutation, and the secondary host may well be, there's been talk that the secondary host is or can be an animal that is consumed, and that what happens is that when people and this is a hypothesis, is that when people eviscerate the animal, because that's usually how they're bought in the wet markets, when people eviscerate the animal, then they become exposed to the virus, and then they pass it on from person to person.
Fascinating.
It's fascinating. It's really interesting.
It is. The next question that I think is interesting that we have out there, and there are many interesting questions flowing right now, but is do we have any idea of what kind of dose is necessary for infection in humans?
We don't. I wish we did. And if you look at the CT values from the few studies that report CT values, let's say from environmental surfaces or something, those CT values are high, and that suggests a really small amount of virus. I'm hesitant to say anything because we don't have information about infectious dose, but the high degree of transmissibility of this virus would suggest a pretty low infectious dose.
Well, kind of going right along with this, one of the other questions that we received, and actually Infectious Dose had lots of questions regarding it, but was a little bit about is there a difference between surviving and being able to transmit based on physical contact and transfer? So it may live on cardboard but not be as likely to transmit, or trapped in the fibers, et cetera, of smooth paper. So any comments on that question?
Yeah, so I think one of the slides I had, this one here, I basically said, we don't know transferability, and it's absolutely true that when you do like risk assessments looking at virus transmission, there's one thing as to, how much of it you have on the surface. The second is that how efficiently do you pick it up if you touch that surface with a piece of food, if you touch that surface with fingers, if you touch that surface with another surface. We don't have any data on that. I can tell you for other viruses like noro, that usually touching a contaminated surface with something that's moist or high in lipid usually results in much higher transfer efficiency than touching it with something that's dry. And that would likely be the case here as well. There was one more thing I was going to say about transfer efficiency. For example, cutting boards is a great example here. And you see this with bacteria as well as viruses, but anything that's got a lot of cracks and crevices, the organism is going to hide in those cracks and crevices, and that will definitely reduce transferability. But those, we don't know how much, but it will definitely reduce transferability.
Okay, another question that I'm sure others on the call are interested in is there any data to suggest whether infection can occur through ingestion?
I was anticipating that. Okay.
I figured you expected that question.
I was, and there is a very, very, very good paper. It's actually an expert opinion that was sponsored by a French agency, and I have two slides in here that talk about the findings of that agency. And I will tell you that this is the only thing that I could find that was even remotely risk-based, panel-based. People really thought about this stuff and really tried to come to consensus. So I think that anybody who's interested in it, and the link to it is at the bottom of the slides. So the two questions that were posed is there a potential of domestic animals for harboring the virus, like in the meat, and could that be a source of foodborne illness? And then the second is the role of food transmission. And I didn't really focus on the domestic animals one because I didn't think it would be as great interest to this particular group. But the bottom line is their conclusion was no, we don't need to worry about, cows having the virus and we getting sick because we eat, beef, for example. But I don't want to. I mean, you can actually read these two slides. I think maybe there's a bunch of things that are kind of informing this concern right now. So one of this is the whole idea of fecal oral contamination of food, since we are finding evidence of the virus in human feces. And you can see here that the stance that the agency took on this, they basically said that it has been observed, but we don't really have evidence that, I want to say this, we don't really have evidence that there is a fecal-oral transmission. Like, we're not infecting the gastrointestinal tract. We're pretty sure we're not infecting the gastrointestinal tract. The second kind of major argument has been about the host cell receptor, which is the ACE2 receptor, and the fact that the ACE2 receptor is present in many different tissue types, including some of the gastrointestinal tissue types. So what's to say it's not infecting the gastrointestinal tract? And the answer to that question really is we don't think it is, but we don't know that for sure. But keep in mind that viruses use a host cell receptor, and there are many, many, many different the same host cell receptors are present in many different tissue types. Okay, but viruses are very tissue specific. Okay, so there are other factors besides just the host cell receptor that are impacting the ability of that virus to attack that particular type of cell or to infect that particular type of cell. So until we know more about the infection dynamics of this virus, we can't say, well, just because that host cell receptor is in that particular tissue, that tissue is going to become infected by that virus. And I think most virologists would agree with that. So I guess and there's a couple of other things, but those are really the two major arguments that people are starting to make. And I think my conclusion, and I believe it's consistent with this opinion, is that it's probably not impossible that people could get sick from eating a food that contained COVID-19 virus, but relative to the other routes of transmission, it would be pretty rare. And this is one of those instances where we've got to look at relative risk, because we have a limited amount of resources. And I think we're using our resources and we're putting our attention in the areas where we're going to see the greatest risk reduction. And that's clear from what happened in China. So to spend a lot of time, saying, "Oh my God, it's the food supply," I think it's probably not an effective. It's not. It's going to get a lot of people concerned about something that's probably of relatively low risk relative to the other routes of exposure.
So we have another practical question from one of our listeners, and the question is, what would you do with your fruits and vegetables that you're buying right now?
What I always do with my fruits and vegetables, which is I wash them off with water and eat them. I'm the wrong person to ask this question. Because I know enough about removal of things off of fruits and vegetables, and I just wash them with water. Okay. I realize, there are people who wash them with soap and water, and if they want to, that's fine. It's not something I would recommend, but I don't think there's any harm in it.
Another question was, and I think it goes back to your presentation, heat would also potentially kill the virus if it were on a food contact surface or perhaps dishes, etc. Is that correct?
Yeah, and actually that brings, because there has been this debate, and I think some in the food industry actually is like, what do we do about our laundry, right? Okay, because we, we're constantly laundering things. And I love that this French opinion that I just showed you was actually also the source for the D-value curves in the presentation that recommended 63 degrees centigrade. Let me see if I can go back up to that. 63 degrees centigrade for 5 minutes or something for killing the virus. 4 minutes at 63 degrees centigrade, and they did a good job. I mean, now heating a surface is a little different. So, and I don't have any guidelines for heating a surface, but so I can't give you guidelines in the way that a D-value curve is constructed, for example. Sure. But yeah, heat should work. Yeah. It's not a very heat-resistant virus.
And then I think another question we have is, if you get it once, are you good? Essentially, can you get it again? And I don't know.
One and done, yeah. one and done. They don't really know. Yeah. The preliminary data that's come out is that the immunity is really short-lived. But it's way too early to be able to make that as a definitive conclusion.
Another question kind of in that same vein is, we hear about asymptomatic people are shedding, and this is causing additional virus. Do we have any more information about how common that is and how that asymptomatic shedding is working?
No. And I think that's one of the big unanswered questions. And I am hearing numbers now. I don't, nobody's given me a reference for these numbers, okay? But on the news, I'll hear something where people will say, well, 4 out of 5 people who get sick, had contact with somebody that they didn't even know had the virus and who didn't even know that they had the virus. And, where that number came from, I have no idea. But I think, I think from sort of a common sense standpoint, I think a lot of transmission is happening from asymptomatic people. Now in the non-envelope virus world, I think we worry. Well, not so much with Hep A, but with Noro, we worry more about people who are post-symptomatic, right? And I think in this case where you have a longer incubation period, which is the case for Hep A as well, you're worried about people who are pre-symptomatic. Now, with that said, we also don't know a lot about post-symptomatic shedding. So we don't know if people are actually infecting other people after they've recovered, because the virus hasn't been in our population long enough for us to figure that out.
Sure. Well, I think we have answered the vast majority of at least concepts here that were the questions. We could probably go for the next 2 hours on additional questions, but I think we want to thank you very much for your time, Dr. Jacobs. We really appreciate your presentation, and I know it was very helpful for me, and this is the second time I've seen a version of it, and I've learned more this time definitely. So we appreciate you taking time to join us. The slides and the presentation will be posted. We're going to do our best to make that happen today, but it could be Monday. And we'll also send out an email to all of the participants once that goes up, so you can go ahead and access that information.
Great.
So once again, thank you for joining us. Great job as always.
Okay. Have a great day, guys. Have a good weekend and be safe.
Thank you.